She got back to you.
Who, Karen? I'm texting her.
She just texted Joe.
Who, Joe?
They need AA batteries.
Okay. Yeah, so we're going to be talking about pre-hospital alerts. And these are specifically our preemptive field notifications referring to STEMI, trauma, stroke, and sepsis. Karen might be joining us from D2. She'll let me know. So she's got the link in her email, so hopefully she pops in. So we're going to look at the use of air medical transport, when to use these pre-hospital preemptive alerts, trauma alert criteria, STEMI alert criteria, stroke alert criteria, and sepsis alert criteria. Those are kind of the overarching themes. When it's appropriate, when it's not appropriate, and only a few trucks have this sheet in them right now. I know A1 does, so I'm going to try and get those back in the trucks. It makes life easy because you can't always remember the criteria. You just remember, oh, this patient might qualify, they might not qualify, but you're not quite sure where they fit on the spectrum. So first we're going to look at air medical transport. It is by the highest medical level EMS provider. So fire can start them. They can request dispatch for them, but ultimately, if you're the highest medical provider on that scene, it's your call if air medical is coming or if they're not. As DART always says, they're happy to spool up and launch and be canceled later. So when in doubt, start them and then cancel them. Not a big deal to cancel them, but it's better to get the ball rolling sooner as opposed to needing them and then not having them. As far as clinical conditions, we're looking at severe respiratory compromise, loss of the airway. They require ventilation. We've got systolic blood pressure less than 90, a MAP of less than 65, so they are circulatory compromised. We've got neurologic compromise, so GCS less than 9, a new normal, or motor less than 5. Significant trauma, which we're going to get into specifically. Burns greater than 20% or inhalation with airway compromise. Any electrocution with loss of consciousness, arrhythmias, other significant changes. We're looking at air medical transport as well. And then STEMI, stroke, and critically ill children, we should be considering air medical transport. There's some cases where we use a lot of this for example, trauma, and other cases where we may not be considering air medical, where it may be worthwhile to get them started and come to BMH. So as far as requesting them, if we're in Brattleboro, our primary contact is Brattleboro Dispatch. Call them and say you're requesting DART, requesting air medical. If we're outside of Brattleboro, we should be calling KCF 4 and 5. Call KMA. They're going to be a much better resource for you. They have policies, they have the LZs. Overall, there's a better dispatch center to get us this air medical resource to where it needs to go. Sometimes they will ask you what LZ you want. Other times they'll send them right to a direct LZ. It all depends. What I typically say, and I know Drew and Mark have kind of said the same things, always transport towards the hospital. Because if things go south, that bird can't fly anymore. Let's look at that snowstorm earlier today. You don't want to be waiting in the middle of Hinsdale, waiting in the middle of Putney for a helicopter that just got turned around. What was that, Drew?
So Mark's been there waiting on the ground for helicopters not coming.
Yeah.
Point of interest, there's a northern LZ in Jamaica that they've attempted to use twice that still remains on the run card, which is not an active LZ that they keep sending us to.
Which one is that?
The one that is supposed to be in a field that doesn't actually exist because it's full of construction equipment in Rossendale.
So don't try and go there.
Just to be aware, because twice in the last couple months, they've attempted to send us to an LZ that's not actually there.
So we should probably be, if they try and send us there, direct them
Fire chiefs are
to
aware, but
go to the Ross and Country store.
because they won't actually, the helicopter won't land there.
Yeah, so go to the Jamaica store, go to the Rossonville store instead of that Northern LZ.
Most towns have preset landing zones through KMA and
Right.
protocols to land the helicopter.
Right, but again, like unless you've got crystal clear weather, it's almost better to designate Onion Field, designate BMH as your LZ, and transport that way. Lillian Gray has a field, so if you're going towards Grace Cottage, you may be able to use Lillian Grace Field as your LZ as well. Because you don't want to be waiting for a bird that's not coming. That's kind of a nightmare scenario. You're stuck, they're not coming, they get turned around, your patient's crashing on you, and you were counting on having that flight crew. Well, now you don't have them. Age, weight, gender, and extent of injuries. They need a weight to launch because if the patient's not going to fit in their helicopter, they're not going to fly. So you need a weight to get them launched. They like to have gender, and they want to know extent of injuries. This might determine if they're going to grab blood or not before they leave. I think they always carry blood. Mark, do you know if they always carry blood on their bird, or does it depend? Yeah. And then tell them where you're transporting to. On certain alerts, they will ask if you want a helicopter. Other alerts, they might just start a helicopter. Always listen. Don't just pick up the radio talk and then put it down and walk away. If you call a STEMI alert to KMA, sometimes they will just start DART and they'll ask you for an LZ. Other times, they won't say a single word, and you may need to actually ask for that resource. So, trauma alert. Put a little helicopter in the corner because this does meet air medical criteria, also meets trauma center criteria. If we were close enough, we could probably just go direct, but unfortunately, Vermont protocol has us limited by 50 minutes. There's not a level 1 facility within 50 minutes. Going the speed limit. Which means there is no level 1 facility within 50 minutes by ground. So we have to go to the local ED first, or put them directly on a helicopter. So we're looking at GCS less than 13. And this is a new change, not baseline. Patients can be baseline 13. So looking at GCS drop of 2 since the injury insult. Looking at a blood pressure less than 90 systolic, or MAP less than 65. And then respiratory rate less than 10, greater than 29, or less than 20 in infants. And we can also say if they're mechanically ventilated, we can justify air medical transport. And you also would transmit a trauma alert to BMH. Same thing with, this is nature of injuries. So nature of injuries, looking at any penetrating injury to the head, neck, torso, and extremities above the elbow or knee. So gunshots, stabs, pike pulls, chest wall instability or deformity, proximal long bone fractures, so that's femurs, humerus. And you can mismatch upper extremities, lower extremities. Any 2 long bone fractures, we can justify a trauma alert with air medical because that took significant force. And then we can look at crushed, degloved, mangled, or pulseless because they need a surgeon now. BMH will not do surgery on that. Cheshire might. If you're in Hinsdale, you're in Chesterfield, it may be worth a phone call to Cheshire. I know that I've called medical control before, and Jim has answered the phone, and he said, yeah, I've got a hand surgeon right here. Just bring him to Cheshire, and we'll do it over here. So, something to think about those resources. Brattleboro doesn't have those specialties. Cheshire might. Maybe worth considering seeing what they have for resources before you determine where you're going to transport to. Any amputation above the wrist or ankle, pelvic fractures, open or depressed skull fractures, and then paralysis. So these also all meet criteria for a helicopter. They all meet a trauma alert criteria as well. What haven't we talked about as far as trauma? That used to be kind of the mainstay years ago. Mechanism of injury. Mechanism does not trigger a trauma center criteria at all. It can trigger a trauma alert, and you should consider the mechanism for a trauma alert to the local hospital, but this does not determine trauma center criteria. So falls, we're looking at adult falls greater than 20 feet, pediatrics 10 feet or twice the child's height. Looking at high-risk auto crashes, so greater than 12 inches to the occupant site, 18 inches any site. That does include the roof. Any partial or complete ejection and any death in the same compartment. Those are all high-risk mechanisms. There's high risk of injury. So you can transmit a trauma alert to the local ED, but it does not warrant air medical transport just because these criteria are met. Actually do an assessment, see what's going on, what your vital signs are, what the extent of injuries are, and make the trauma center criteria based on that. It's not just based on the mechanism. Any pedestrian or bicyclist thrown, run over, or greater than 20 mile per hour impact is a significant mechanism. Any motorcycle crashes greater than 20 miles per hour, and then any ATV collisions. Why ATV collisions specifically? Minimal helmets, recreational vehicles. The patient's probably going to take it up an over pathway, and there's a high likelihood of having bilateral femur fractures. So significant risk of injury from being thrown, lower extremities, pelvis, abdominal injuries. So we can consider mechanism for a trauma alert, but it's not an absolute trauma center activation and not an automatic air medical activation. They may be started based on this criteria by dispatch. So do an assessment, figure out what's going on, and then make your own determination to either continue or cancel that helicopter. So what action should we take for a trauma alert? Initiate paramedic resources if they're not already dispatched. Transmit a trauma alert to dispatch with your destination facility. This is important. If you don't tell them where you're going, they won't know who to call and tell them that you're coming. So dispatch has to know that destination facility. Request their medical early if they meet the criteria. Transport to the ED for stabilization, or in the case of BMH, you can bypass the ED and go to the helipad, and that's not an EMTALA violation. We're bypassing for the purpose for air medical transport. It's not an EMTALA violation to bypass that ED. The hospital's not going to get in trouble by you bypassing to put them right on a helicopter for a higher level of care. Now, how long can you sit on that pad for? In theory, as long as you have to. But generally speaking, and Mark, if I'm incorrect in saying this, please correct me, but I'd say up to 10 minutes of pad time is acceptable to get them higher level of care. Otherwise, once they're in the ED, they have to have a doc-to-doc. They have to accept them at the receiving facility, and that patient may be delayed in their care to the trauma center. Mark, what are your thoughts on that, about waiting for a helicopter on the pad for up to 10 minutes?
Use your best judgment, because a lot of times they're really off on the time estimate.
Mm-hmm. Drew, what are your thoughts?
On the severity of the patient. So, if you've got a patient that is actively crashing on you, that's why I prefer to see you transport towards the hospital versus away from the hospital.
Correct.
Another piece of information to think about, we've had a couple of recent calls for mutual aid in the Dover area that have resulted in air medical. And they're insisting on flying into the airport over there, which is not near a hospital. So just a warning that as the mutual aid calls to Dover continue, we may want to think about flying those helicopters back towards hospitals as opposed to sitting in Dover for 40 minutes to find out that it's logged in.
Right. Most schools on Route 9 have LZs. Marlboro School, they have a field. You can probably drop a helicopter there. So if we're going to that Dover area, we're trying to come back towards us. You've got those Wardsboro schools. We've got Dover schools. Most schools have fields. They've got playgrounds. They've got sports fields. You can land a bird there. They'll fit. You're looking at 100 by 100 feet. At night, 75 by day. We can usually find that. And then just general trauma care. Focus on the airway. Focus on hemodynamic stability. Do what we're good at. Take care of the patient. Next, looking at STEMI alerts. So ST segment elevation myocardial infarction. Kind of the big one, the heart attacks. So we're looking at an automated interpretation of meets ST elevation MI criteria. It will look exactly like that, in all caps, in bold, shouting at you saying, this is a big deal, this is a problem. Or the paramedic automatically interprets it manually as a STEMI. So that'd be 1 millimeter of elevation and 2 or more anatomically contiguous leads. There's consistent reciprocal changes. Just because the ECG says STEMI does not always mean it's a STEMI, especially if the patient has no symptoms. They've got no chest pain, no shortness of breath, nothing else going on. They look fine. May not consider it a STEMI. Under STEMI alert criteria, under the rescue wing guidance, there has to be consistent chest pain. There has to be consistent signs and symptoms, and it has to consist with acute coronary syndrome. So chest pain, dyspnea, diaphoresis, weakness, abdominal pain in females over 40, back pain in females in general. Not all chest pain is ACS. And look at the totality of the circumstances, look at the big picture, and then make a determination of, is this an acute coronary event or is it something else? If it's an acute coronary event and it meets your ECG interpretation, go ahead and call the alert. So what does it look like? It looks just like that. Meets ST elevation MI criteria. And then later on down below it says inferior ST elevation, consider acute infarct. You're looking for these 3 stars on either side in the big bold letters that look angry. That should scare you. It means something's going on. Anything that this monitor does that's big, bold, and scary, you should pay attention to. I know we've had a few recent cases where we've had the right thing done, an advanced EMT or an EMT basic did a 12 lead, and this was the result. They called the alert based on this. They started the appropriate resources, and then it got back down because it wasn't an actual STEMI. But the right thing happened. It's not wrong to call the alert on the front end. It's not wrong to start those paramedic resources, and then let the paramedic ultimately keep the alert continued or back it off. Keep that helicopter continued or back it off. So actions we should take: request the paramedic if not already dispatched. Transmit a STEMI alert and request air medical from dispatch. This is one of the cases where getting the helicopter coming early is important, but your goal is not to transport to the helicopter and put them on the helicopter. You're starting the helicopter so that we can almost hot cot in the ER and then put them right back on the helicopter once they get medication from the ER, once they get clot busting drugs from the ER. Because the window is 90 minutes. 90 minutes from first medical contact to get them to primary PCI. That's up at Dartmouth in the cath lab. That's as large as that window is for the best success. So to elongate that window and buy more time, we have to get them to local ED. This is BMH or Grace Cottage. They will get TNK and fibrinolytics there, and then they're going to get back on a helicopter. But at least having that crew start their way, getting the helicopter coming, buys us more time. It speeds up the entire process if we activate that helicopter versus the ER activating it. Mark, what are your thoughts?
The only thing that never happens, the hot cot, they never do it.
No.
No matter where we go, they insist on the patient going on their bed.
Every single time. But at least getting the helicopter coming, because they're in the ER's care, they get lytics, they have to have a receiving doc. They have to have an accepting. So at least getting the helicopter coming, once they get an accepting, we can put them right on that bird and get them out of here. And this is protocol 3.2 or 3.0, which is the ACS. Especially up in Townsend, this can be a huge problem. Because you start the helicopter, they go to Onion Field, we need to go to Grace Cottage. Grace Cottage loses their mind. Well, if they don't start the helicopter, and they may not, it was never started. If we start it, they're less likely to turn them around, typically what I see from ERs is, well, they're already coming, we'll just keep them coming. And we can manage them that way. If we go by ground, this patient's going to be at least an hour and a half, factoring in half an hour in the ED. We don't have enough time. We're not a perfect system. If you put them on the helicopter, there's not enough time to get them to cath lab. So we have to go to the ED and have them get lytics. Stroke alert. This has changed, and it's going to change again. The last change was last year, and it increased the window from 3.5 to 24 hours. So if they time last known well is less than 24 hours, we can call a stroke alert. This used to be 3.5 to 4.5. The next iteration coming around with the new protocol set is going to be along the lines of the LVO criteria, which is the large vessel occlusion, and using the fast ED scale. And we'll receive training on that once new protocols get rolled out. But it's basically a way to detect if it's a massive stroke or a submassive stroke is what we're looking at. For a massive stroke, with the LVO criteria, the window is still going to be 24 hours. For a submassive stroke, where there's minimal deficits, it's going to look at like the 3.5 to 4.5 hour window. So there's going to be a bit more clarification, a bit more precision on this stroke alert. But right now it's 24 hours across all stroke patients. Check a blood sugar. If it's not 60, correct it to 60 and see if there's still deficits. Any abnormal finding on the stroke scale, so if there's facial droop, if there's arm weakness or drift, and abnormal speech, any one of the three factors in a stroke alert. Just call it. Essentially with this alert, you're banging pots and pans, saying there's neurological compromise, they need a CT right now. That's what we're doing. And then we're also looking at the deficit is unlikely due to head trauma or other identifiable cause. So if it's due to head trauma, you wouldn't call a stroke alert, you'd probably call a trauma alert instead, because they've got decreased mentation, abnormal neurologic function, and that would classify as a trauma alert because they have a known head injury. So if they have that head injury with showing stroke-like symptoms, that would fall under a trauma alert, and it still triggers all that trauma criteria. We don't call these enough. A lot of these patients are really borderline on determining where their mental status is. We can probably call more stroke alerts because really what you're looking for is that immediate CT. And that CT's determination is this an ischemic stroke or is it a hemorrhagic stroke? And if it's a hemorrhagic stroke, they don't give clot busting medication. If it's an ischemic stroke, they can give clot busting medication. Mark, do you have any points on stroke alerts? Okay. So actions to take. Transmit that stroke alert via dispatch with a receiving facility. If they're having a rapid decompensation, significant altered mental status, consider paramedic intercept. A lot of strokes can be handled at the advanced DMT level. They don't always require a paramedic. There's not much a paramedic is going to do except in the way of airway management, and if they're decompensating with significant hypotension or hypertension, in that case consider a paramedic. But we really should be looking at the airway management aspect. Most airways with strokes, they're not going to get worse. They've been the way they are for about at least 30 minutes, an hour, sometimes more. The risk of airway decline is very minimal. However, if they start to have a rapid airway decline, there's nothing advanced EMT can do in protocol to correct that. Respiratory arrest, an advanced EMT cannot insert an I-gel. An AMT can only insert an I-gel in cardiac arrest per protocol. So BVM ventilation is what we're stuck with. However, a paramedic can manage that airway a bit more aggressively. They can nasally intubate. They can put an I-gel in for respiratory arrest. They can intubate for respiratory arrest. So the paramedic has a lot more options to manage that airway aggressively on the front end before that airway is fully compromised and now you've lost the airway. So if we're looking at that, then we really should be calling that paramedic sooner rather than later. As far as other actions to take, establish IV access and give an initial 250 ml bolus. We're looking for at least an 18 gauge proximal IV. That's the AC space or higher. The reason for this is for CTA and a contrast CT. Typically, the first CT they acquire is it's going to be a non-contrast CT of the head. And then, almost without a doubt, they'll go back in 20 minutes and they'll get a CTA and a contrast CT. So grab the 18 gauge peripheral IV, preferably an AC. If not, get what you can get. At this point, any access is access, because we don't always have to get the IV for the contrast. They can give TPA through a 22 in the hand if it's patent. If they do that initial non-contrast CT of the head, and they determine that it is a full ischemic stroke within the time windows, they can give the TPA through those lower peripheral IVs. So anything you can get is better than nothing. If you look at it and you think, I might go to get an 18 gauge in there, but I can definitely get a 20 gauge in there, get the 20. You know you can get it. Any access is better than no access. And then if there's airway decline, manage it aggressively on the front end. OPA, NPA, whatever it takes. We may cause increased ICP, but if you can't ventilate, there's a problem. So be very aggressive on the airway if we start to lose it. And don't worry about the blood pressure. Unless it's 220 over 120, it's really not considered hypertensive. It may be high, maybe 140s, 150s, 180s, 190s systolic. There's nothing we're going to do pre-hospitally, nor should we do pre-hospitally, to correct that blood pressure. That blood pressure is being corrected to maintain perfusion pressure in the brain. Because as that pressure in the brain increases, especially for hemorrhagic strokes, if we don't correct that, we're maintaining perfusion pressure in the brain. If we drop that systolic blood pressure, we are no longer getting perfusion to the brain. Just because they're hypertensive, it is not an indication for nitroglycerin. We should not be giving nitro for a stroke patient that is hypertensive. We don't correct hypertension in the field in EMS. And if we do not use nitroglycerin. There are much other options to use, especially in the case of a stroke, to manage that hypertension. That's not our call to make. That's the ER's call to make. Mark, what are your thoughts on actions for stroke? Anything else that you would recommend?
No.
What are your thoughts on always calling a paramedic versus an AEMT handling 9/10s?
Time is huge. If there's going to be any delay, the patient's much better off getting in. And then the other thing I would add, really watch out for getting an antiemetic on board. It's probably a good idea because a lot of these patients will vomit. Absolutely.
Zofran, Reglan. If they're already vomiting, Zofran's worth a shot, but it might not do anything. So if you're with a paramedic, have them consider Reglan. Reglan will stop the vomiting. Zofran will not. You can go ahead and give it a try, but it's probably not going to work. Alcohol prep pads, give it a shot. It's something. It may work a bit better than the Zofran in this case. It's hard to say. Mark, do you have any experience with alcohol prep pads versus Zofran?
There's a study that proves that those work pretty well.
Yeah. And this is a great case for preemptive Zofran because Zofran does work on serotonin. So it's working on the brain specifically. So when we're having a neurological event, Zofran's targeting those receptors before they get compressed. It's not a nauseous and vomiting event based on GI upset. It's based on a neuro event. So the Zofran should actually work pretty well for this event. Now we're going to look at sepsis.
Real quick.
Yeah.
One of the things that wasn't up here for the stroke, what was weakness on specific side weakness?
Arm drift.
Okay.
Yeah. Just because they can't squeeze adequately doesn't mean they're having a stroke. It's something to factor in, and it kind of looks at the totality of circumstances because I've called stroke alerts based on visual disturbances, visual changes. Like their left eye is only seeing the color red. Like look at that and take it with some clinical significance. If you think that what's going on is an acute event, the worst thing you do is you call the stroke alert, and it's not a stroke. Because you should get met in the ED by the provider and a nurse. And the provider will do a rapid assessment, literally maybe 10 seconds, and they'll say, go to CT or go to a room. And the worst thing that happens is that they think it's not a stroke, and you don't go to CT immediately. That's the worst that happens. Really, you're banging pots and pans, you're clearing CT, you're getting it available for the potential of a neurological event. Because they're supposed to be clearing CT, making available to nurses and a provider, respiratory, when you call that alert. That's what they're supposed to do. Does it always happen? Heck no. But it's what's supposed to happen, is that they're supposed to be clearing CT, making resources available for a potentially critical patient. So, sepsis alert. We're looking at, this came out in 2018. It used to be a single sepsis protocol and sepsis alert protocol. They divided it between sepsis adult and sepsis pediatric. So the sepsis adult is clearly you're an adult, you're over 18 years of age, and there's a known or suspected source of infection. It's going to be everything from a recent surgery to an indwelling catheter, G-tube, trach, recent pneumonia, nursing home, period. The fact they're in a nursing home is a suspected source of infection in my mind. If they're in a nursing home and they've got an altered mental status, my first thought is that they've got a UTI and they're septic. That's usually what happens. So we're looking at temperature greater than 101 or less than 96.8. And you only need 2 of these criteria to rule in for a sepsis alert. Heart rate over 90, respirations over 20, systolic blood pressure less than 90, or you can also go with a MAP less than 65. And then new onset of altered mental status, or if they've got a baseline diminished GCS, diminished mental status, we're looking at a loss of 2 points or so. Any change in that mental status from baseline that's decreasing. If they have a lactate greater than or equal to 2, sometimes these facilities, nursing homes, they'll routinely pull labs. So if they give you a sheet of labs and you notice the lactate is over 2, you can add that to your criteria. Then end-tidal CO2 less than 25. And this end-tidal correlates directly with the respiratory rate, correlates to the heart rate, and what this is showing signs of, it's showing signs of compensation for metabolic acidosis. That's what it's really showing. So any 2 of these criteria, typically the criteria I can hit are altered mental status and respiratory rate, or respiratory rate and heart rate. When you add in end-tidal CO2, there's a very, very slim chance we're going to miss these patients. Is there anything else that you're seeing, Mark, that's been triggering for sepsis?
And one thing to be careful of, a lot of patients now, AFib, RVR, it's compensatory, so you don't necessarily want to try to treat the rate. You might not be able to control it because of what's going on from an underlying pathology. So it's becoming more frequent that a lot of the elderly people are seeing AFib with rates 140, 150, 170, 180, but it's all compensatory because their body's trying to take into account what's going on.
Absolutely. And on a similar topic as the AFib with RVR that we typically see as a compensatory mechanism, if there aren't any beta blockers, their heart rate may be in the 60s. And they will not be compensating to show you sepsis. They may not meet that heart rate criteria because they're beta blocked. They may also have profound respiratory distress because they're on beta blockers and they can't oxygenate well. So when you look at that beta blockade as worsening of the sepsis, especially like a pneumonitis, which is very common these days, severe pneumonias compounded by inhibiting the bronchodilatory properties of their body. Now we're dealing with a patient that, one, can't increase heart rate to compensate, but they also can't breathe to compensate. So we're looking at multiple facets that can profound this sepsis. In pediatric, who guessed the age? Less than 18 years of age. So it's a known or suspected source of infection, as always. And with pediatrics, we have to have two criteria present. The first criteria present is a temperature, greater than 101 or less than 96.8. The second criteria is an accelerated heart rate. And the case to be careful with this is, again, some pediatrics who have chronic heart problems, they are put on beta blockers at a very young age. So if they're beta blocked, they will not meet this second criteria. So take that into account. And if you would predict that they would have an accelerated heart rate, go ahead and call the alert. It's better to call it, get the resources allocated, than to not call it. And they also have to have one secondary sign of organ dysfunction. Altered mental status, a cap refill less than 1 second, so that's flash cap refill. Their body is trying very hard to perfuse. Or it's very delayed over 3 seconds. Any mottled cool extremities, and then a lactate greater than 2 or end-tidal less than 25. And what this mottled cool extremities replaces is it replaces the blood pressure criteria. You can also look at it from a PALS perspective of what does PALS consider hypotensive shock. And you can use that criteria as well. And that criteria is 70 plus 2 times the age, up to the age of 12. So that'll give you a rough guesstimate of where their blood pressure should be. Anything less than that would be hypotensive shock. Or you look at the cool mottled extremities and factor that in also as a sign of shock. And this chart over here shows what the heart rate should be. So of course, the younger they are, the faster the rate goes. So just kind of look at that chart. It's in the protocol book, and go by that when you're making that heart rate determination. We're never going to remember this. This is too much. Just look in the protocol book. If you're thinking it's close, if you're thinking it's above where it should be, just call the alert. So what action should we take for a sepsis alert? Transmit the alert. The mainstay of sepsis treatment is early antibiotics, early vasopressors, and a 30 ml per kilo fluid resuscitation. Most of these patients get over-resuscitated by the ER. So start the fluid. Consider a paramedic if they're hemodynamically unstable or the airway is compromised. Start IV fluid and document how much you're giving. On pediatrics, try and calculate the weight-based dose as best you can. Coming out in 2020, you're going to see a change to sepsis treatment. Current recommendations for adults go up to 4 liters of fluid before they get vasopressors. For adults. Pediatrics, it's 20 mLs per kilo times 2 or 3. That's changing. They're saying that after the initial liter of fluid, we start vasopressors. They get epi or norepi after 1 liter of fluid. So for AEMTs, if you hit that 500 mark, you best be calling a paramedic. They may not be able to give push dose levofed because that doesn't exist, but they can start giving push dose epinephrine to increase that blood pressure. And we can use that to manage that blood pressure stability. And we're looking at keeping it at a MAP of 65 or above, systolic above 90. So lots of changes coming down the pipe for sepsis. They turned out we've been over-fluidizing them for years and years and years. And the more fluid they get does not equal more survivability. It's higher mortality. So if you hear a patient getting 2.5, 3 liters of fluid, especially going inter-facility, it should be looked at with some scrutiny. Ask the doc why. Talk to the nurse, find out why. Because it may make more sense to back them down to maintenance fluids and start vasopressors if they need that much fluid. Because at this point, they're just Michelin Man. That's all they are. Like, you're Michelin Manning the person, and it's making them much worse because now that fluid hat will shift back into the lungs and put them in heart failure. Mark, any thoughts on sepsis changes, where we're going.
And you're probably gonna see ringers used a lot more
Yep.
than normal saline. Especially going out. A lot more of the patients on ringers.
Warm fluid, if they're, no matter what, if you give them cool fluid, you're going to put them into an acidotic state, more so. Either way, normal saline is still acidotic with a pH of 5.5. But by giving them the warm fluid, you're at least helping them a little bit. You don't want to cool them off too much. They're warm because they're fighting an infection. We don't want to break that fever. Tylenol can break the fever, and that's what Tylenol is for. It's not the cool fluid that's going to break that fever. Additional questions, thoughts, concerns? Mark, anything else you want to add?
Just a heads up, it looks like on that IMIS sheet that I mentioned before in the new protocols, there's probably going to be something on infectious diseases for an alert.
Uh-huh.
So that might be a new alert level, because that's such a big issue, especially like around MMR and some of the other diseases. They need a heads up to make sure they go into negative pressure isolation. So that could be another kind of thing.
So, stuff to think about.
Thanks, Jeff.
All good changes.
Is there a sign-up sheet?
I did not put one out. I'll put one out.
Thank you.
Thank you.